Hey, I'm Haddas from Dallas, Texas.
My name is Bassel Diebo from New York.
Yigal Samocha, also New York.
Yeah, thank you for coming today.
Absolutely.
Today we'll talk about balance. So let's start with you, Yigal. I got a question for you. What is the most common testing when you evaluate balance in your clinic, and which one you use the most and why?
Well, as a clinician, I rely, like all clinicians, on history and physical. So, a lot of it is asking the patient questions about their fall history, their walking, their balance, and then physical exam findings, looking at them walk, just seeing how their balance looks to me, and then more specific tests like Romberg and sit to stand, and those kind of most commonly used tests. There's other ones that are a little bit more specific, but I would say those are by far the most common ones that probably do within the first few seconds of seeing a patient and talking to them.
Yeah, great. What about you, Bassel? You're heavily working with deformity patients. I know you have a whole different definition for balance. Can you tell us more what is balance for you?
Yeah, absolutely. For me, there's a difference between balance and alignment. Alignment is a radiographic concept. It's a structural concept. Balance is more of a dynamic functional concept. The best definition for balance is Dr. Debussy's definition, which is alignment in motion. Meaning if we can get to address the deformity into a specific alignment that help us obtain the motion the patient need, then that's the goal of the treatment. So for us, there used to be a lot of, I would say, misconception that balance is alignment. For us, spine alignment is the radiographic concept where we measure SVA, PI minus LL, pelvic tilt for our patients in addition to other measures. Balance is neurosensorial, is dual tasking, is muscle envelope, and all these kind of neurosensorial functions. So there's a quite difference between both.
Yeah.
So outside of the things that I described, what can you add? How can we measure balance more accurately? We get a better idea of what balance actually is for our patient.
Yeah, this is a good question. And let me ask you, share with you a funny story. The first time I attended NAS, almost a decade ago, I was listening to a great talk of deformity patients. They keep talking, saying bad convoluted economy, good convoluted economy. And I simply raised my hand and asked, okay, so what is actually a bad and good convoluted economy? And this is what will lead me to develop a method to quantify the convoluted economy. So the most simple way, just to refer your patients to a gait lab if you have access to that. If you don't have access, I'll talk more about it later on in the conversation. But if you do have access to a gait lab, you can refer your patients. We're going to put a bunch of sensors on them. If it's a human motion tracker or EMG sensors that can measure the muscle activity, then we have them perform a balance test. It can be a Romberg test, time up and go, eyes open, eye closed, depending on the level of functionality. Then we can able to provide you a score for your balance effort, for the dimension of the convoluted economy, and your dynamic compensation, how you compensate. Then you can take this score and plug it in our classification system that we develop and tell you what is severity level of your balance of your patients. And then the same thing, you can do it before intervention, before surgical intervention, after surgical intervention, before physical therapy, after physical therapy. You can do it testing for the long run annually for deformity patients, AIS patients. And just get it, every time you send them, you can get a score of what is the size of the convoluted economy, the balance effort, and dynamic compensation.
That's awesome. I was pretty excited when I read your paper, Ram, about convoluted economy, and because we have been really trying to understand this concept better and try to put data behind it and try to understand how patients stand in their own cone or their own balance. So, I mean, the gait lab is great news, but if which is most of us in the country don't have gait lab, and maybe if you bring that question to your administration, they will be like, sorry, it's too expensive. So what do we do about that? If I'm a resident or a surgeon or a spine care provider that wants to know what is the balance of my patient, how do I measure the convoluted economy without sending patients to gait lab that I don't have?
Yeah, this is a good question, and actually this isn't the first time I'm getting these questions. I mean, like you said, most of you don't have an access to a gait lab. So we work on solutions. We try to find a cheaper and more feasible solution for you, surgeon. I mean, one paper we published earlier this year, we just used a force plate. You're just standing on a force plate, like basically a fancy bathroom scales. Do the Romberg test on this force plates, and we build a model and prediction to tell you what is the size of your cone of economy. So think about it. Whenever you're taking the vitals for your patients and you take the scale and everything, you can do the same thing on the force plates and measure the cone of economy right away while they're waiting for you to get into the room. On top of that, we got a couple of other technology that we use, like if it's a smartphone apps that can be used, IMU sensors, and all of this can help you to define the cone of economy in a much cheaper way, and if you don't have access to a gait lab. So outside the lab, in the clinic, at home, in the physical therapy clinic, and other places.
That's pretty sweet.
Yeah. So Yigal, let me ask you a question. So how you can use this detailed information as a surgeon or part of your practice?
That's a great question. I think that number one, you can use it just to help you make the diagnosis. If the patient comes in and there's something looks funny about their gait, you want to get a little bit better idea of, is it a vestibular disorder, is it a neuromuscular disorder, is it a spinal deformity, is it a myelopathy or radiculopathy, antalgic gait. There's a lot of things that can cause a change in their balance, a change in their gait. So you can help get a more accurate diagnosis based on how they're walking and how their cone of economy is, as give me an idea to correlate with my exam findings and with my imaging. After that, I can also use it to kind of estimate the prognosis, have a better discussion with the patient of what they can expect. And I can also use it to rate the severity of their balance problem. So the scale that you came up with, the Haddas severity scale for the cone of economy, I think is very useful to where I can see how bad somebody's disease is. And then after surgery, be able to kind of track their recovery, show that to the patient, share it with them, and also kind of help validate that what we did is working and kind of continue to reevaluate how we can make that better.
Yeah, this is great. This is giving balance a whole different definition when you get all these numbers.
Definitely.
Yeah, now let's ask you a question, Bassel, about compensation. I know you published many papers about compensation in deformity patients, AIS, but why do you care about patients' compensation, and how do you actually quantify this type of compensation in your patients?
That's a great question, Ram. I think the main point of identifying compensation is to differentiate between compensation and driver of deformity in the deformity world. So if the patient come to you, and we have been fortunate that in the past few years we have the full body radiographs that enabled us to look at patients from head to toe. The issue that we had, that we are so subspecialized that sometimes we do great physical exam for certain pathology, but there's often no objective kind of assessment, like for example even X-rays in this point where it shows you the head to toe for the patient. The thing is that looking at the patient as a whole like that make you see whether there is a compensation distal or distant to the pathology site. For example, if you have a flat back or lumbar degenerative pathology or deformity, what are the hips positions? What are the knees positions? Because sometimes this patient might show up to adult reconstruction surgeon and say, "Oh, my knee hurt," and then obviously there will be thorough physical and history, but the actual pathology that led to a compensation at the knee level is actually a spine pathology. It might sound simple, but it has been really recognized recently. With you hear talks about hip spine syndrome, you hear talk about cervical shoulder syndrome. Even in the peds world, there's a lot of talks about scoliosis versus hip dysplasia, what to do first, and when they come concomitantly together. So identifying if this behavior, whether it's a thoracic hypokyphosis, pelvic retroversion, whether it's a hip flexion, whether it's a compensation or a driver of deformity, is so important, because we want to address the driver. If we address the compensation, we miss the driver, and we're going after a mute point. So that's why compensation is important, and identifying it is very, very important.
Yeah, and you're absolutely correct. And I know that more and more, when reading more and more your papers and your group papers, you guys start looking in more details about the hip joint, about the knee joint, on the ankle, knee, hip alignment, in addition to the spine.
Absolutely.
And this is very important. Yeah, I agree with you.
Well, can your technology kind of help define where that is? I mean, can these motion sensors and Gait Lab, can we help narrow down where that compensation is coming from?
Yeah, absolutely. So second version of the Cone of Economy papers actually define a specific dynamic compensation for each patient. And we have three major compensation we're talking about standing. The first one is the ankle strategy that most of us are doing. You're just standing, your body is rigid, okay, and most of the compensation coming from the ankles. This is really common for most of us. For more severe cases, we see the compensation coming from the hip and trunk. It's called the hip strategy. So we see our patients swaying more. This is where you see the cone of economy much bigger, and usually we also see a lack of core muscle activity with this compensation. The third type of compensation is a knee strategy. Whenever our patients don't feel comfortable, so they try to squat to get the center of mass closer to the ground, and they feel they're more stable with the closer to the ground. So far, based on the research, we didn't find most of the patients using a combination of this compensation. When again, the most common one is the ankle compensation. In more severe cases, we see the hip and knee compensation. A recent study we did, we actually took 400 patients with different disease, starting from adult deformity, cervical myelopathy patients, spondy, failed back syndrome, and just the degenerative disc. And we actually took all of these patients on their cone of economy test. And in this paper, we defined for each cohort how does cone of economy look like, how much balanced effort, because each of the compensation of these cohorts is different. A cervical myelopathy patient is swaying because, due to a different reason compared to adult deformity patients. And then we were able to profile each cohort, the cone of economy, how much the sway, the dynamic compensation, and the size and the balance effort. And then, like you said earlier, Yigal, we just take their number and plug it in our classification system and tell you how severe our patients are, and try kind of to plan what is the optimal treatment for them. Are we going to retake them to a surgery, or we want to try another round of physical therapy and exercise to get them stronger and the core stronger, maybe try injections.
Yeah, that's some great information to add to what we're already doing, kind of to give us the data to support some of the things that we think that we're looking at, but actually, I can actually quantify it now.
Yeah. Okay, so we cover a great topics today. Let me ask you a final question, and I'll start with you, Yigal. So how do we care about imbalance patients, and what do you do with them?
Well, I think to kind of build on what Dr. Bassel was saying, these patients aren't seen in a vacuum. A lot of times they have multiple pathologies, especially in my patient population, a lot of older patients. As an orthopedic surgeon, I see patients that certainly have shoulder pathology or hip pathology, and then they may also have other underlying neuromuscular pathologies. So what we were talking here today about is being able to get a better idea of where those problems are, where the primary problem is, what the compensatory problems are, and that really fosters more of a multidisciplinary approach. So I can work with my neurologist, I can work with my arthroplasty colleagues as well, and not just say, I think it's more the hip, or I think it's more the back. I can actually say, look, we have some more concrete data and saying that we really need to address the hip first, or we really need to address the neuromuscular disorder, or we should address the spine first. And then that'll actually foster a closer relationship with colleagues, number one, and also ultimately help the patients more because you're treating what they actually need treated.
Yeah, and you're absolutely right, because the method we develop for the cone of economy and dynamic compensation can pinpoint exactly where is the problem and have you consider what to treat first. Now let's ask you the same questions, Bassel. So how do you care for imbalanced patients, or deformity patients?
Yeah, it's a great question, and I think in terms of deformity, again, the full body assessment, obviously after, thorough history, physical exam, you look at the patient as a whole. You see for example, lumbar deformity. And then distally, for example, you have hip arthritis. The patient have a little bit of shoulder pain with neck pain. So now we always think about, okay, let me call my joints colleague. Hey, listen, I'm about to do a major spinal deformity reconstruction. Are you considering doing total hip replacement? How are you planning to do your acetabular position? This communication now is way more faster than before. In terms of deformity patients, again, identifying where is the driver and what to address first is becoming a norm. In terms of dynamic testing, we use Dubusse functional test, for example, in the clinic from our standpoint, where we measure the functionality of our patients. Dual tasking component of that test address balance. We do have gait lab, so we send our patients to the gait lab. And then the major question always, what does the patient want? For example, if I am performing a spinal fusion on a patient that wants to have activities that are more, golf or farming or sitting, maybe I want to consider fusionless or not, non-fusion options or tethering options for scoliosis kids, for example. It really depends what the patient wants to do and what their future functionality is. So caring for me, it's a passion to care for deformity patients, whether it's adult or peds. And I think the balance and dynamic is assessment of them is just the future of it. I mean, from my end, I'm going to be focusing on that in my career, and I encourage everybody to do so. And I think we're on the right track.
Yeah. Great answer. Let me ask you one follow-up question. Deformity surgeons heavily rely on radiographic for pre-surgical planning. Do you think in the future we'll see the dynamic components factor in for the pre-surgical planning?
Oh, absolutely. I think the dynamic profile of our patient is very important. The soft tissue component where, okay, we know that this muscle group have, for example, fatty infiltration. If we think about balance, we would say like this patient does not have the dual tasking ability to sustain this alignment plan or this surgical plan. What do I do to match the patient dynamic or balance profile? And that's, again, start with talking to the patients about what they want to do, assessing their ability to sustain or adapt to a new surgical, for example, in deformity, a new alignment I'm going to give them. Should I give them the 40 years old alignment or 50 years old alignment? Should I give them this kind of balance profile, but they don't have it? Maybe I should prehab them. So assessing dynamic functionality of the patient is absolute must to me. And I think it will help us tremendously tailoring our care for the patient.
Yeah, this is exciting about
Absolutely.
the future, about the dynamic. Thank you very much.
The more data we have, the better, really.
Yeah.
So,
Yeah,
absolutely great.
absolutely.
Well, thanks for having us.